Okay. So, good morning, all. I am Dr. Vishnu Prasad, Professor and Head, Department of Surgery. Today, I would like to extend a warm welcome to all of you who have come from different places. So, the theme of this workshop is to introduce you to the ERCP procedure. So, many of us in our department have been doing upper GI scopy, colonoscopy, and side wing scopy. Our intention was to progress further, and many of you might be having the same intention since you have come to this workshop. So, in this workshop, we have 5 cases listed, but we will be doing only 3 cases, the simple ones. So, the most common problem which we encounter is choledocholithiasis. So, the first case will be that choledocholithiasis is a young fit patient of 46-year age. So, having small stones in the common bile duct. The second case will be a periampullary carcinoma, a patient having cholangitis, is 80-year-old man. So we'll do a sphincterotomy and a stenting. And the third case again will be choledocholithiasis, where we'll be doing sphincterotomy and a stone retrieval followed by stenting. And the other 2 cases are standby. One is a pancreatic divisum, and the last one is a carcinoma gallbladder, which is inoperable, which needs stenting. So I hope it will be a good experience for all of you. So at 3 p.m. we have an online lecture by Dr. Ishwaramurthy from Lotus Hospital, who will give you further tips and tricks in biliary cannulation and setting ERCP. So thank you all for. So we will be starting in another 5 minutes. Thank you. So today we have Dr. Mahadevan, who is actually our alumni from JIPMER. So he did his MD from here. And following that, he has done DM from Madras Medical College, and he has been working in global gynecological hospitals. And he has a ERCP experience since 2009, more than 14 years. So he's an expert endoscopist. So he will tell you all the steps of ERCP procedure, and I will hand over this microphone to him. So we will be starting in another 2-3 minutes. So if you have any question, meanwhile you can ask, and we will be starting. Thank you.
So good morning, everybody. I'm Dr. Mahadevan. First of all, I would like to thank Dr. Vishnu Prasad for the kind invitation. It's my privilege to be here back to JIPMER after 20 years. And it's nice to be here. And today we are going to have, I think, yes, enumerated, I think we have 3 cases minimum to demonstrate how to do ERCP. So I'll be performing the procedures. While doing that, I'll be showing how to interpret the scope and what are the steps involved in cannulations, how to retrieve the stones. We will be having different type of cases, I hope. So we have some malignancies, so how to perform ERCP is a difficult anatomy. And so I hope most of you have seen ERCP procedures earlier. Before the case is getting ready, and I just want to brief, probably we may have lectures in the afternoon. Basically, before doing an ERCP, you need to have some hands-on experience or mentorship with someone so that you'll get trained either by watching, then start doing under supervision, then you can do it independently. And the most important thing is you need to have a right indication for the case. Borderline case is always a risky. So important thing, need to take a proper history, even though you may have a resident or register to brief the history. So you need to examine and to convince yourself what is the case. And right indication is the most important thing. Borderline indication, there are always ERCP comes with the complications like pancreatitis, perforations, bleed, and infection is a very serious complications. That's the reason why ERCP is not being performed by everyone. And every case is unique. That's the reason to have a right indication. And apart from that, you need to have a proper history, including medication, what they are taking, including antiplatelets or anticoagulant. These are the things where many times patient may not give you. You need to go through the drug list, what they are taking. Sometimes they will not give you a complete list. Patient may be consuming if you ask is, for example, if you ask, do you have any cardiac illness, they may say no, but some physician might have started with antiplatelets like aspirin or clopidogrel for the risk of having a cardiovascular disease. So it's very important. They need to stop at least 5 to 7 days prior, and need to assess for anesthesia fitness, including all basic labs you need to have. Then you should have an imaging to support the diagnosis or the right indication. Most commonly, we have a stone disease uh, presenting with an obstructive jaundice or a cholangitis, or sometimes stones with cholangitis with a pancreatitis with an ambulatory stone. That is the most common scenario. Then subsequently, you may have malignant biliary obstruction, especially distal biliary obstruction. And the other indications are post-op complications, maybe bile duct injuries and so on. So you need to have good imaging. Prior to that, you need to have a roadmap. That's very important, actually. You cannot go and do a procedure on table and decide like what to do. So before going to the procedure, I hope, I think we have a senior resident that to brief the history. I hope he will brief the history, then we'll go to the case. If you have any questions, you can always, even a smallest, simplest question also, you can always interact. The more the interaction, we'll learn more. So we'll go to the case. Probably someone will brief the case.
A very good morning to everyone present here. I cordially invite you to the 6th JIPMER surgery update and the first ERCP workshop. I would like to invite our esteemed moderators of a workshop, Dr. Uday Kumar sir, Professor, Department of Surgery, Dr. Rajkumar sir, Additional Professor, Department of Surgery, Dr. Shanmugam sir, Additional Professor, Department of Surgery, and Dr. Sudarshan sir, Associate Professor, Department of Surgery. Proceeding with the first case scenario, it's a 42-year-old male with no known comorbidities with the diagnosis of cholelithiasis with choledocholithiasis. A 42-year-old gentleman presented with complaints of abdominal pain over the right hypochondriac region for the past 5 months. It was insidious in onset, dull aching type of pain, which aggravated on food intake and relieved with analgesics. There was no history of any radiation or migration of pain. Patient also complained of history of jaundice 5 months back. There was no history of any vomiting or no history of any fever. On examination, per abdomen was soft and non-tender, bowel sounds were present, and there was no organomegaly. We did basic investigations. His urea creat was 30 and 0.89, sodium was 137 and potassium 3.6. Total bilirubin was 0.45 and direct bilirubin was 0.08. Liver enzymes AST was 40, ALT 31, ALP 94 and GGT 15. Coming to the imaging, first we did an ultrasound. Ultrasound showed a liver with a normal size and no IHBRD and no surface irregularities with mild to moderate fatty liver. Gallbladder was partially distended with multiple tiny calculi noted in the neck of the gallbladder with an average size of 3 mm. There was no sludge or no GB wall edema and no peri-GB inflammation or collection. CBD was not dilated and pancreas, head and body was visualized, which was normal, and rest of the pancreas was obscured by bubble gas. It was diagnosed as cholelithiasis with no features suggestive of cholecystitis. We proceeded with a CT and we also got an MRCP for the patient. CECT wise, a dilated CBD was noted. MRCP wise, few void filling defects were noted in the gallbladder as well as in the mid and the distal common bile duct.
Just before going to the case, I'll just tell you what are the scope position, patient position, and who is going to assist. With me, Dr. Deepak is there. Anesthesia is going to give anesthesia for me. And we have my technicians, Mr. Loganathan is here, and we have other technicians and people are there to help me out. To moderate, Dr. Vishnu is there actually to guide me during the procedure and give comments, and he can also help me out during the procedure. And generally, what I'm using is a Pentax scope, ED3490TK. This is a duodenoscope. Mainly it's used for a therapeutic purpose. It's just have an elevator. This is not a forward viewing scope. It's basically a side viewing scope. You can see the lights and cameras coming through the side It's a side wing scope that because the duodenum, C loop of duodenum, we see the papilla. We can't visualize in the end on view, so we use a duodenoscope here. And generally, we prefer to have a patient on a prone. That is more easy because we don't need to change, and we need to have a fluoroscopy compatible table. And there are we generally sometimes depends on the patients. When this particular patient for live purpose we have intubated, but not all patients are intubated. Most of the time we do it under IV sedation. We prefer to do it on the left lateral because it's much easy for the anesthetist. And when it requires, we put the patient in supine so that even when the airway is compromised and quickly you can rescue by intubating the patient. But most of the time it may not happen, but it's much easy for anesthetist. For when you are doing procedures like pancreatic endotherapy or any difficult anatomy, we put the patient in prone so that you don't need to move the patient. Patient will be static, and we can move the fluoroscopy. We'll get a very good image out of it. So now I'm going to start the procedure. So probably many of you may have an experience of handling the gastroscope. This is same as of now intubation, same as an upper GI endoscope. Here there are no endoscopic visual clues to reach the papilla, at least for the initial intubation per se. It's mostly often is a blind. So probably just to revise your endoscopic skills, here you are going to intubate just over the tongue. You're going to touch the posterior part of the pharynx. Then what you're going to do is slightly big wheel up so that it make a bend like this. It just curve over the tongue. Then you can just reach the pyriform fossa. Then once you reach the pyriform fossa, keep the big wheel away so the scope is straight and slide little bit of air and little bit of push, either the clockwise or anti-clockwise rotation. You push the scope, it will go into the cricopharynx. Then subsequently, rest of the things I'll show you during the demonstration. I hope you can see me and you'll see the endoscopic image. I hope you are able to see both. The most preferable both for the anesthetist as well as for the radiographer point of view. But we do it start with the left lateral. That's much easier for the IV sedation. And then when for imaging purpose, sometimes we, for example, we want to see the hilum much better. We want to see the anatomy of the biliary tree. We put the patient on supine. We turn the left lateral to convert it into supine. Especially hilar lesions, you put the patient on supine. So mostly it's preferable to have a prone, but for anesthesia point of view, it's not very easy unless the patient is completely intubated so that they'll be peaceful. Otherwise, the patient will have a lot of respiratory discomfort, the tongue fall will be there, breathing difficulties. So this is more comfortable in a prone, but for practical point of view, left lateral or supine will be better. But when we are looking at the papilla, in each view will be different. The most comfortable is a prone. Left lateral also is comfortable, but supine, most of the fluid will come close to the papilla. Whenever you inject some fluid or put some water, the water will pool near the papilla. It's always interfering your cannulation or any therapeutic procedures.
Agree, sir. Another thing I would like to know whether you are doing check endoscopy for all the patients with end viewing scope or
And generally we don't do it actually, but always we take the history, whether the patient is having the dysphagia. But this is always a gut feel. You should always have a feel that we should not force to intubate the patient actually. So it's a right question actually, because for the beginners, better they can have whether they have a patient is having any cricopharyngeal strictures or a web, or patient is having any other malignancy. We have seen sometime growth in the lower esophagus presenting with obstructive jaundice. So it's very important to have a normal anatomy before reaching the papilla. But in an experienced hand, you will have a feel and you have a partial view. I'll show you when I'm going in. We'll make the side wing into forward wing. For example, if this is the scope, I hope you're able to see the image. This is a scope. This is a.
we are not able to see the
This endoscope actually. So we make the scope big wheel down so that we'll be facing like this. Use the side wing into forward wing. Only in the lower esophagus and the stomach, not everywhere. So just intubating the cricopharynx is always a blind. So for a cricopharyngeal strictures or anything, you need to have an idea whether the patient is having any dysphagia or not. No dysphagia, you can intubate. There are any difficulty or any resistance, we should never push it. We always change to an upper GI scope, verify, then we'll switch over to a side viewing scope. It's a very good question.
Another thing would like to know what is the preparation of the patient, sir? Is it as same as that of upper GSCOP or any specific preparation we'll do?
Preparation prior to the ERCP.
Yes, sir.
For the patient preparation, you meant?
Yes, sir.
Generally, 8 hours fasting is sufficient. Then the antiplatelet or pre-anesthetic checkup. There are no special preparations. So overnight fasting. There are cases when the patient is have a possible gastric outlet obstruction. It's important to place an nasogastric tube, aspirate. Otherwise, during intubation, when you are doing without an intubation, there is a risk of aspiration. So it's very important. Have an important history. That's why I highlighted. So you need to have a pre-procedural diagnosis. What are the possibilities? What you are planning to do it? That's very important. Otherwise, you may have a gastric outlet obstruction or sometimes gastroparesis that always patient can vomit or patient can aspirate. So it's very important to know what is there inside.
Okay, sir.
And maybe before things are ready, I'll just say brief about our instrumentation, what we generally use. Apart from our endoscopes of various brands we use, we need to have a carbon dioxide. Here we are using air. In our unit, we use for every patient carbon dioxide because carbon dioxide, you know that it's 150 times faster absorption. Even when you use it for longer period of time, is carbon dioxide absorbs very fast. When you do procedures for half an hour, 1 hour, sometimes air can distend the small bowel, the stomach will distend it. Here, patient is intubated, but unintubated patients always have a discomfort, but breathing difficult will be there. So the most preferred is on carbon dioxide. So it's very important that any therapeutic you need to have a CO2 insufflation. That's the most important thing. Then you need to have a good diathermy, either ARB or Olympus, whichever the unit you have. Actually, you need to have basically an endocut option. That should be very important. We are not using cutting and coagulation current manually. So nowadays everything is computerized. It is an automated one, so that it will be processed, a combination of cutting and coagulation current. So the processor will deliver it. So you don't need to really press the cutting or a coagulation. So important to have a good electrosurgical unit is very, very important. Then you need to have a fluoro-compatible tables and good fluoroscopy unit. So that's very important. You need to know where you are going, where your guide wire goes. Do you want to see the stone? After injecting a contrast, you need to have a clear anatomy of the bile duct. Is very, very important. So you need to have a fluoroscopy. And apart from that, all accessories. You need to have a good accessories to have a good successful ERCP. That's most important. Many times people may not understand unless you keep the accessories. New one preferably. Ideally should be in a single use, but in India it's not possible to have a single use accessories. So after any procedure, they need to clean it and store it in a proper way. And most of the ERCP accessories are hydrophilic. It works with the water because you want to pass an accessory to the working channel or through the endoscopic accessories. Everything we use a water for lubrication. So it's very important to dry it and keep it used. Otherwise, it may not come for not more than one or two procedures. So good accessories important. You need to have all accessories. The basic instruments are all either as commonly used as a sphincterotome. We don't use cannulas nowadays because sphincterotome we can straight away, you can cannulate, then you can make a cut, you can inject, everything you can do it with the one instrument. Then you need to have an accessories with this guide wire. Guide wires, we use different type of guide wires. For initial cannulation, for my own personal usage, I use a hydrophilic guide wire for a cannulation. There are many ways to cannulate the papilla, either a guide wire or contrast assisted. We prefer a wire guided cannulation, so that we need a hydrophilic, fully hydrophilic. We use a Termo, it's a fully hydrophilic guide wire. Most commonly used is the angled wire. Then you need to have we can't use the hydrophilic wire for all your procedures. You'll switch over to other wires, like you use a Visiglide or a Jag wire. So use a stiff wire for using other procedures. Then you need a stone extraction balloon of various sizes. The most commonly used is a 12 to 15. That's the most common size. We are not going to remove a big stone more commonly. So less than 1.5 centimeter stone is the most commonly we deliver through the ERCP. Otherwise, you need to go for either a lithotripsy or a laser to pulverize the stone, then bring it to smaller, then deliver the stone. That's why you need to have at least 12 to 15 balloons, stone extraction balloon. Then you need to have baskets. Generally, there are different type of baskets are available. One is stone extraction basket, is just to retrieve the stone alone. Another is lithotripsy basket. You just crush the stone and deliver it. So these are the baskets you need. Then you need a contrast, radio opaque contrast to identify the stone and just visualize the biliary system. Then you have to have stents. After removing the stones, you need to have deploy the stents. Plastic, metal stents are available. There are straight stents, variable from 5, 7. More commonly, biliary, we use a 7 and 10. For pancreatic, 5 and 7 size stents, 7 French stents are we commonly use. And in case of malignancy, we use a metal stents for a palliative purpose, sometimes even for a therapeutic purpose also, to avoid cholangitis. So as the case goes, and we will be discussing each one of it. And this is about brief about the instrumentation. So I hope you got images, endoscopic image.
No, we are not getting the
Not yet.
endoscopy.
Okay, so we can discuss till the things are getting ready. If you have any questions, we can ask and then we can discuss.
Sir, how you take care of the ergonomics of endoscopist positioning the monitor, how the patient table and height of the table and where the assistants you position. So can you just briefly elaborate on that?
I'm sorry, actually, the audio is not very clear, actually.
How ergonomics taken into consideration when you do this procedure, sir? Ergonomics, how you position the monitor, table height, your position.
Lot of echoes there, so I'm unable to hear it.
Hello.
Hello.
Sir, regarding the ergonomics, the position of the endoscope is monitor, table height,
Yeah, you're just talking about the
fluoroscopy.
ergonomy. Yeah, this is the actually the way you. So you need to stand here to the head end of the patient, and preferably anesthetist. You can just camera can.
Show the external view. This endoscopic view is there, but it is not on.
Yeah, it's getting ready. Endoscopic images are getting ready.
By the time that external view, let them.
Yeah, sure. So preferably we need to have an monitor on the head end of the patient, mainly on the left lateral position. Then you will have an anesthetist on the side. You can just view this area. So the anesthetist, we have an endoscopic nurse will be holding
that previous view will be okay, sir. This is endoscopic view. We are not able to see anything.
No, we are not going to. I'm not intubating. I'm just showing the ergonomics, how patient is being placed, how the instruments are placed actually, where the fluoroscopy and where the screens are supposed to come.
Yes,
because
now you're able to see, sir.
Yeah, go ahead. So because you'll be intubating the patient in facing the patient. After some time, after intubation, you'll be having turned the patient towards the right. Then only your scope will be in a standard position. Then most of the time, either you will be standing towards the monitor or you'll be facing this way. This is the way you stand, because this is a more stable position, so that scope will not fall back. So we will not be doing entire procedure like this, because most of the procedure will be doing either facing the monitor or going towards the right. So this is the best way to hold the scope actually. It's a good question. Second thing, the fluoroscopy monitor also prefer to have either you connected with here or connected to the opposite side. So either if it is possible here, because we cannot turn this way and see the screens. So all your screens should be either in front like this is the best way to have a screens, including your fluoroscopic images. And preferable to have a monitor here, so that you can also observe. Sometimes when patient is under sedation, so you can also observe whether the patient is heart rate or vitals are within normal limits. We check the ETCO2 whether within the normal limit or not. Though we have a dedicated anesthetist, so it's our the person who is performing the procedure also have a responsibility to know whether the patient has become sick, when to stop the procedure or pause the procedure. It's very important no. So in front of you, everything has to be there. This is the ergonomics of doing an ERCP.
Okay, sir.
And here we are going to use the RB here. Actually, this is a YO3. This is the mode what commonly used an endocut. That's a commonly used mode, endocut I. I meant for incision. There are two modes are there, endocut I and endocut Q. Endocut I for incision mainly for ERCP, Q for polypectomy. These are two commonly used mode. This standard settings been given actually, like where you can see here, the I'll show you. So endocut, the two meant for effect. This effect will tell you about the duration of your coagulation.
Please on
And-
the external view. Yes, sir.
Now you are able to see.
Yes, sir. Yes, sir.
So here you can see this is an RBYO3. This most commonly, most of the endoscopy unit will have this instrument. So good surgical endosurgical unit is very important. What mode we are using is an endocut I. That's the most commonly used for ERCP. I meant for incision, Q for polypectomy. And here we are using effect 2. 2 is meant for effect 2. 3 is duration. Another 3 is interval. So basically you have an effect of 2 coagulation effect. 3 milliseconds is the cutting duration. Cutting interval is 3 milliseconds. That's how we go. You don't need to have so much detail, but you should aware that there is something called endocut. It is fractionated combination of cutting and coagulation current. It's delivered by the microprocessors. We don't need to do anything. Just press up the pedal. You can just, you must have seen the pedal here, the yellow and blue pedal. So we are going to use only the yellow pedal. Just press the pedal. I'll show you when I'm doing the procedure. Just press the pedal, so you'll get a continuous cutting. So you will get the effect of endocut. So you don't need to switch over from cutting and coagulation. In olden days, before this endocut was available, what generally we start with the coagulation initially, for initial coagulation to avoid a bleed, then start cutting, then coagulation, cutting. We just do it an alternate way. But nowadays you don't need to do that. System will deliver the energy in a whatever settings, pre-setting way. It will deliver it. So you just focus on only just press the yellow pedal. Unless the patient is having a bleed and you want to stop it, use an blue pedal to stop. Major coagulation, you want to use it, use the blue. But only just focus is yellow. Just use endocut I, press the yellow pedal to just do a sphincterotomy.
What will be the setting for electrosurgical units with which are non-RB with these features?
But many of the instruments are coming nowadays. Most of the companies are coming with the endocut, but we are not much aware of it, because initial days, some 15 years back, we were using some brands which can deliver endocut, but it's not on a predictable way. Sometimes there will be overcoagulation. There is a risk of zipper cut. That's a big problem for the beginners. So if you use press, if it is endosurgical unit, electrosurgical unit is not delivered properly, you have a zipper cut. So it's preferred to have good quality electrosurgical unit for your therapeutic endoscopic unit. It's very, very important, especially not only ERCP. Nowadays, I hope you will be knowing that endoscopy is no more a diagnostic field. We enter into endosurgery, because now we started doing ESD, endoscopic submucosal dissection, for early malignancy, starting from esophagus, stomach, as well as colon, even the right colon. Cecum, we do it. And we do peroral endoscopic myotomy as good as Hellers. And so it's now the field is changing from purely into diagnostic into the therapeutic. It's very, very important to have a good electrosurgical unit.
Thank you, sir.
So I hope you must be seeing the endoscopy view. Shall we go there?
Sir.
Just focus. Actually, I'm just going to start the case. I think you must have heard that it's a young male presenting with an bile duct stones. I think the MRCP which showed multiple small stones. The real challenge must be doing an ERCP for a normal size duct. Always there is when you do ERCP, you should be very careful, because it's not easy. When you have a dilated duct with multiple stones, it's much easy to do ERCP. On a normal size duct, I saw the MRCP image. I think you must have seen the images in the screen. And these ducts are small, so likely to have difficulty during the cannulation of the bile duct. So I'm going to, can you just focus the camera towards the patient? So what I told you, the scope should be straight like this, and it should not be bent.
AV team can switch to single mode, external camera view.
I hope you are seeing the external camera.
Can you bring it into a single picture? Can remove that PIP mode. AV team.
No. If you have a picture in picture is good. So outer, they can switch over anytime.
This external view can be in a bigger view, and endo view can be in the PIP mode. Small.
Sir, good morning. Sorry for that interruption.
Big-
The AV team, the
Yeah,
entire
whenever-
image is reversed actually. The entire image is reversed.
Yeah, whenever I'm
The
setting
image
it.
view has to be reversed. It
Yeah,
is
now
not
it cannot
normal.
be empty.
The orientation is very difficult.
Sorry.
Sir, the entire image is reversed. The reversed mapping is there. The view has to be reversed. Your right side is become left side here.
Okay.
The entire view has to be reversed. Otherwise, orientation is not possible.
So orient-
Okay, sir, we can proceed like this, no issue.
So I'm going to start. I hope you are seeing the external image now.
Yes, sir.
Okay, so I'm going to intubate the patient. The scope should be straight. What you're seeing, the scope should be straight, not to be bent actually, make it straight. So now if I just focus actually, like I'll put my scope just over the tongue. Now you can switch over to the camera in endoscopy view. Picture in picture mode, okay. Slightly head. Yeah, okay. So generally it's a blind intubation. Just over the tongue, you have to push. You have to feel actually, you'll reach the posterior pharyngeal wall. Then use a big wheel up. Just slightly till the patient. Somebody has just lift from the other end. Some technician or someone. Yeah, so just lift the left shoulder. So that's much easy to. Somebody can lift actually, can call some technician so that. So the intubation may be very tricky in a prone position. The head will be slightly topped. So I'll generally tell the assistant to pull the left shoulder, right shoulder, sorry, the right shoulder, so that it's more of a left lateral. So once you go there, so now I am just into the esophagus. Can leave this patient. So generally, if you big wheel up, generally you won't see anything. So I'm keeping the big wheel away so you can start seeing the lumen. Can you able to see the lumen now? Like a forwarding scope. I'll push my scope gently. Now you can. I'm entering into the OG junction. Can you able to see the image in the screen?
Yes, sir. We can see very nicely.
Yeah.
Sir.
So I just enter into the stomach. Like generally, when you intubate, no, you will straight away go into the fundus. So what you need to do once you enter into the stomach, you need to inflate with a little air or a carbon dioxide, then turn towards slightly onto your right. So change your body position is very important. I'm just inflating. I'm not done anything. I'm just inflating the scope and turn little right so that I can see that. Fundus is no fluid. Very important that in sedated patient without an intubation, you need to suck the fluid. Here, not much of fluid. Some bile is there. You need to suck. Then it slowly introduce the scope. I think from far away you can see the pylorus. So the most important thing is keep the scope straight and keep pushing. Here you can see the fundus above and big wheel and down. As I said, actually when you're going inside, big wheel away, make the scope as a forward wing scope. This is almost like a forward wing scope, but here the scope is like bent down. So you can't go intubate in this view actually. So this is something called sunset sign, where you can see the like a sun. What you need to do is you have to use the big wheel up gently, then slowly enter. Now we are entering into the first part of the duodenum. Still, the job is not over. You want to know where the D1, D2 junction. Here, every time I'm keeping the big wheel slightly down so that you're able to see the entry clearly. So I slightly push the scope little bit. Here you can, I'm at D1, D2 junction. Here you need to do two maneuvers. I hope you are able to see the endoscope handle.
External camera can zoom out a little bit, sir. External camera can zoom out.
So this is a small wheel and this is a big wheel. What you need to do is small wheel right fully and lock it. Small wheel right and lock it. Then insufflation, turn your body more. I'm just turning the body more here. I've not done anything here. So now you start seeing the papillas. What you're seeing in the top of the screen is a minor papilla. The other one is a major papilla. So what you need to do is you need to pull your scope. You can pull your scope. So mostly you'll reach the papilla here. But most of the time, either you'll be overshoot. Every scope will have a different ergonomics. So most of the scope you'll go beyond the papilla. Then you have to slowly withdraw. Here you are straight away. You are enfacing the papilla. I hope you are able to see the papilla.
Yes, sir. Yes, sir.
So there are different types of papillas are there. The one is a flat one. There are papillas with very similar to that papillary mold with multiple the folds are longitudinal folds will be there. Some of the papillas will have a diverticulum within the diverticulum or on the side wall. Here we have a fair, good-looking papilla, not very flat, no diverticulum, periambulary diverticulum. Here I'm going to use an accessory from Boston. This is the triple lumen sphincterotome. I'm going to use a hydrophilic guide wire, that is angled guide wire. It's most commonly used in most of the gastroenterology ERCPs. So this is the sphincterotome, which is coming out. Most of the time, what we generally do, we lock the accessory here, lock the accessory channel. Then once the accessories hits, then relax it, bring the accessories out. So now my technician is just adjusting the guide wire. So most important thing is just examine the papilla. You should not in a hurry to cannulate, just like that, go inside, just cannulate. Examine where the papilla, can you just pull the wire in? I'll just show you what are the parts of the papilla. This is the frenulum. So this will guide that this is the median of this. So papilla goes like this. This is the axis of the bile duct. Where the cannula, you can see this is the center axis. So this is the frenulum that will guide you. It's a 6 o'clock position. And then this is the papillary mount. So there is only one or two folds are there. This is the duodenal fold. This is the upper end of the papilla. So till here, the papilla is there. Even if you want to cut, you reach up to here. This is the 100% complete sphincterotomy till you reach the papilla. So what I'm going to use, the wire guided technique. So my technician will keep the guide wire 1 or 2 millimeter away. So the important is the accessory, what you are seeing is coming from the 3 o'clock position, should go towards the 11 o'clock. It's like that. So now you can see it's coming from 2 or 3 o'clock, reach towards 11 o'clock. Ideally, the papilla should be in the left upper side of the screen. Where you can see the screen, I hope you are seeing the endoscopy view. It should be on the left upper side.
Yes.
If you have it, then it's a difficult time. Now, whatever I am showing, if you preferably to have it here with your scope maneuver, actually, either you keep your scope more on the right or left, slightly push or pull, you will get a different view. So if I push, pull, you can see that different views of the papilla and different positioning. With that, you have to cannulate. So I'll bring the cannula out. So what I'll do is gently touch the papillas. There are papillas where you can see clearly. So this papillary opening, you can see over here. This is a papillary opening. So what I'm going to do is gently my wire is gone in, so I'll gently pass the cannula in, then I'll change a position. Can you just bend little? So just most important thing, just to just engage the papilla into the. So you can see now slowly it's engaging. So what I'll do, I'll tell. Can you just bow? So you know that the papilla is not straight; it's from below upwards. The scope should be preferably in a semi-long position. There are different scope positions there. One is a semi-long. That's the most ideal way. Long scope we don't use it. Short scope most often we enter into the pancreatic duct. So this is semi-long position, and you touch the papilla at 11 o'clock. Keep the bow little bow so that you engage it, and ask my assistant to pass the wire. Just before passing the wire, I'll ask our technician to just screen the fluoroscopy to check my scope position and wire position. Can you bring the screen here if possible? The next case. No, this way or here somewhere. You can just move the machines. So almost I'm into the bile duct. That's how I gut feel. So probably when looking at the cannula and the sphincterotome, you can able to see whether the wire or the cannula is going into the bile duct or in the pancreatic duct. Mostly in the pancreatic duct, the scope will be in a short scope position. Should be straightforward actually. Here, what we are using, we are accessing the papilla from below upwards. You can see the papilla up. You are viewing the papilla from below upwards. It should be the direction. And similarly, the axis also from 2 to 3, it should go up to the 11 o'clock. So that's the right way to cannulate the bile duct.
And we have the fluoroscopy image, sir.
So they are, yeah, they'll get. Can you just bring it more closer? Or you can just come this side so you can get an image. Can you screen here? Should. No, you just bring the CM position here. Just move the machine here. Or you just open this actually so that it's much easy to operate ourselves. Just release the knobs so that it will move. You have to release the locks. Yeah, so you can screen now. Now you have to rotate like clockwise rotation. Yeah, screen more. Put the scope level down. Yeah, screen. Now you have to move the machine down. You can relax your knobs actually. You don't need to. The screen. Screen. Or if you relax the knobs and give the pedal, then we can monitor, adjust. So I think you can see that the guide wire is going just parallel to the spine. That
Yes.
will tell you that you are there in the bile duct. You're already in the bile duct. So now I'm lucky. It's not that actually like we use various techniques. Sometimes you are best of your efforts. Multiple times you enter, guide wire may not go. So it's not that actually I'm just doing, but over years you'll get an experience. But it's not that every time it's easy to cannulate the bile duct. Every papilla is different. Just release everything. You just release இதெல்லாம் எடுத்து விட்டுருங்க நாபில் எடுத்துருங்க no not that knob you lock it lock you release that sideways and to and fro okay can you just rotate to I mean reverse direction can you put a reverse right left no right left reverse mirror image no this upside down do it again this is upside down you'll have a reverse R one more R will be there yet or you can rotate no problem rotate fully full rotation rotate I'll tell you till it stop some more this hold you can just do it in a reverse direction you put press a button you can reverse change again do it clockwise rotation clockwise you are doing anti-clockwise just do it what I'm telling just clockwise rotation stop so now I hope you are able to see the fluoroscopic image
Yes, sir, we could see, sir.
Yeah, so
can you
what you
describe
see-
the finding?
yeah this scope is in like a hockey stick appearance that is in
Sir,
a
1 minute, sir. Can that be made into a bigger picture?
yeah
single
external
picture?
image can you change to external image
Yes, sir, we got it.
yeah can you able to see
Yes, sir.
yeah the scope is in a hockey
Again,
stick
the switch back. Yes, sir, we can continue, sir.
so scope is in a hockey stick appearance and you can see that the spine is very close to the on the right side of your screen
Yes, sir.
the guide wire which is going parallel to that tell you that you are there in the bile duct in case if you are crossing the spine it means that you are in the pancreatic duct so what I'll do like I'll ask my assistant I'll push my cannula a little more deep so I'll screen once again and see you can see very well that cannula is there beyond the scope and the guide wire most probably into the left hepatic duct. Can you appreciate the image?
Yes, sir, we could see very nice.
Yeah. So what I'm going to do is, I'm going to do a cholangiogram right now. So see the size of the bile duct. So before doing an ERCP, the most important thing is size of the bile duct, size of the stone, mainly the distal end of the bile duct. Stone versus the duct ratio. So that is very, very important. So now we are going to get the cholangiogram. The ideal way is put a cannula deep into the hilum. So I'm screening. So now my technician started injecting contrast. I'm injecting the contrast right from above and I'm just bringing the cannula below so that we don't inject too much of contrast. You can see the stone here. Can you see the stone?
The mode has changed now, sir. Yeah, it's fine.
So I'm
Fluoroscopy image, please.
can you see a square shaped stone?
Yes, sir. Yes, sir. In the CBD.
Then there is look like another stone at the hilum, more on the
Yes,
close
sir.
to the right hepatic duct.
Yeah, close to the left.
And anyway, I'll bring the cannula down. I want to inject more. You can see one more stone down just below the papilla, below the scope.
Just below the scope. Yeah.
contrast. So now we have an image. I hope we could able to see 3 stones. Sometimes there may be air at the hilum. They're very sure that there are 2 stones. Stones are close to less than, 7 or 8 millimeter stone. Bile duct also close to 10 mm. So you measure the scope, size of the bile duct in comparison with the scope. You can see the fluoroscopically, endoscope diameter is 13.5 mm. That is the usual diameter. So take that as a 13.5. So approximately the bile duct is 10 mm. The stone is 7 or 8 mm. That is the size of the stone. We don't have an image, fluoroscopic calibration. So you can, like radiology, intervention radiology, you can tell you that what is the size of the stone or a duct. So this is an arbitrary way of measuring. So can we switch over to the endoscopy view? I'm going to do a sphincterotomy. Before that, I'll ask my assistant to change to the guide wire. Now we have a hydrophilic wire. And what I'll do, first I'll push my catheter deep inside. So now you can see 3 stones actually. I'll ask my assistant to change a guide wire. You can see the bile is coming into the catheter. Can you able to see, appreciate that?
Yes, sir. Yes.
So the most important thing is sphincterotomy. It's very important that actually your axis of the sphincterotomy is very important, because you know that the bile duct axis is 11 o'clock. We don't cut straight away at 12 o'clock position. So between 10 and 11 or 10 and 12, that is a usual axis. As I told you, the frenulum is 6 o'clock. So I prefer to go by 11. I'll make sure that wire deep inside. So my technician is putting the wire into the right hepatic duct. So now what I'm going to do, pull the catheter out, sphincterotome out. You can see that the wire, cutting wire. So I'll ask my technician to bow the sphincterotome so that, so we'll get a cutting wire with the bowing. We'll get a proper tension on the sphincterotome. So what I'll do that, so if you see that, I don't do sphincterotomy with my elevators. I don't do like that. It's preferred to use your scope to direction of your sphincter. So you can just, for a just demo purpose, I'm just showing that. I'll just move my scope up or down so that to direct the sphincterotome in a right way. So that's the right way to do a sphincterotomy. So now I'm going to cut. Okay, so I'm going to cut. Generally, you can see various marks in the sphincterotome. The blue mark is the beginning of the cutting wire. At least the cutting wire should be 1/3. You can see that there is a gray, brown color mark. At least you should be there very close to the papilla. Otherwise, you won't cut only the superficial part. So here, at least you have to keep little inside. Now I'll be start cutting. As I told you, I'll press the blue button. Already I've seen the markings, and so I'll slightly adjust. So I'll be going to cut now. So that's because of the smoke, sometimes you will not get a proper view. So what I'm doing, I'm continuously cutting. I'm not pedaling. So every time I'm not stopping, I'm just continuously cutting. I'll adjust my scope, make sure that it goes in the right direction. So once I suck the air, I'll get a better view. What I'll do, adjust the knobs, will push my catheter deep inside. So in this case, actually, if you do a sphincterotomy, wide sphincterotomy, if you do a balloon, it will come. For a demonstration purpose, what I'll do actually, I'll do a sphincteroplasty so that our job is much easier. So now I'll do. So when I'm looking at the cholangiogram, the images, the duct is very big. Probably you can just focus on the fluoroscopic image. The bile duct is dilated till the lower end, it will exchange. So now the idea is to do a sphincteroplasty. Sphincteroplasty is large balloon sphincteroplasty, where we do a sphincterotomy. Then we are going to dilate the papilla, not the bile duct. We are going to dilate the papilla by using a CRE balloon, 12 to 15. That is the size we commonly use. Normally, we don't dilate the papilla beyond 15 mm because the risk of perforation is high or bleed is high. Here, what I'm going to use a CRE balloon from Boston Scientific. So to dilate the papilla. So my assistant will be exchanging the sphinctrodome. We can see that jag wire, which has a alternating black and yellow color, will tell you that every time wire is in place or not. So you don't minimize, you don't need to use a fluoroscopy to make sure that your wire is there or not inside. So because you will be using a lot of fluoroscopy. So to avoid that, this is the endoscopic clue that actually your wire in place. Once in a while, I'll check whether the wire is there. I just push my wire deep inside. Now I'll ask my technician to use the 12 to 15 mm CRE balloon. I hope many of you know that the CRE meant for controlled radial expansion balloon. It means that a single balloon will get at 3 different diameters. So this is the balloon, non-compliant balloon. Basically, a single balloon with a different pressure, it gives you different dimensions. So a single balloon, we are going to get 12 mm, 13, 14, and 15, 13 to 15 mm. So we are going to use a 13 to 15 mm balloon. Start from 13 with a different PSI. It will give you a 13, 14, and 15 mm. So that our sphincter will be enough, we can just dilate enough so that we can deliver the stone without much difficulty. Before this technique, what generally we do, we do a very good wide sphincterotomy, then try to use either a balloon or a basket, crush and remove, because the small diameter of the papilla cannot deliver, at least the stone sizes, I hope it's close to 10 mm. Now it appears to be slightly big, it's just filling the bile duct. I hope the sphincteroplasty is a good option at this point of time, so that we can able to deliver the stone without much difficulty. Otherwise, even still we can able to do it with a basket, but again, it's a cumbersome procedure, procedure related bleed. I mean, procedure time also will be prolonged. So if you have any questions, you can ask me. I hope it's clear. The plan, if you have any other options, you can always discuss with me.
What is the proximal extent of the sphincterotomy?
What is the proximal?
Extent up till what you will
Cut.
cut? Yeah.
Sphincterotomy, normally we cut up to the duodenal wall. As I told you, here. I have not done a full sphincterotomy here. Normally, for a large balloon sphincteroplasty, you don't need a wide sphincterotomy. Normally, what we advocate is a wide sphincterotomy. A good sphincterotomy is sufficient to deliver a stone of 5 or 7 mm stone. The stone's diameter is big, stone size is big. We prefer to have a balloon sphincteroplasty. For that, you need this is almost like episiotomy. I would say that it's almost like episiotomy. You direct the cut towards away from this thing, pancreatic duct, because without cutting sphincter papilla, if you do a sphincteroplasty, the risk of pancreatitis is very high. So you do a sphincterotomy, minimal sphincterotomy. I've done a moderate sphincterotomy, size sphincterotomy. Now I'm going to. So now you can see the guide wire is in place. So the balloon is entering here. The most important thing is, just wait. I don't want to dilate the balloon on the side of the stone. I'll just want to push little. Yeah, it's a little balloon. No, you can put a balloon little. So we'll see under the fluoroscopy. If you have a good to have a fluoro, can you just focus? Can you see?
The fluoroscopic view.
Fluoroscopy, can you switch over the fluoroscopy?
Please focus that fluoroscopy view a little lower down.
Just lower, just
lower.
screen. Just focus the screen alone. Can you see that?
No, lower, that CBD lower end is not visualized.
Not visualized?
Little down, sir.
You can little down.
Yeah, little down.
Yeah. Now you are able to see that? You
Little
can see
down,
the
sir.
scope, and the balloon is filled with a contrast, and you can see the waist. That's
Yes,
the
sir.
sphincter. With the balloon, the dilatation, the sphincter is dilated. So I'll just see once again the sphincter the waste will slowly disappear. I don't want to inflate too much. Now you can see that size of the bile duct and the balloon is almost same.
Yes,
It means that actually you can deliver the stone without much difficulty. So the most important, you do a sphincteroplasty. The only issue is you may have a bleed. Now you can switch over the endoscopy view. Can you switch over the endoscopy view? Can you see now?
yes,
So the balloon is, now you can see the balloon is fully inflated. Now I think we have dilated up to 12. So we have dilated up to 12 millimeter, so 1.2 centimeter we have dilated.
How we can know it, sir?
Now we have a pressure monitor. We have a pressure with a different atmospheric pressure. For example, we have a, now if you focus the camera here, this is the Alliance gun. This is the Alliance gun. Can you able to see?
Yes, yes.
So this is the Alliance gun to inflate the balloon. And this will be attached to the syringe where there will be a pressure monitor here, pressure gauge. You can see the pressure gauge here. And you have a different reading. With a different pressure, it will give you a different balloon dilatation. With that, we can able to say what atmospheric pressure, what balloon size we are dilating.
Yes.
So now, now we have done a balloon dilatation. I think waste is almost only very minimal. I don't need to completely disappear the waste actually. So that what I'm going to do, slowly deflate, because most important, after dilatation, I may expect some bleed. So what I'll do actually, I'll slowly deflate. I'll ask my assistant to stop and wait for some time, then slowly deflate. Now you can see, can you able to see an endoscopic image?
Yes, sir. Yes.
So there is very little ooze is there. I hope it's not going to bleed anymore. It's a very little ooze. I think you can dilate little more because the opening is appears to be slightly less. Can dilate up to 13 mm. What I'm planning actually, like by appearance, it may not be just a visual appearance. The dilatation is yes, I think now it's dilated. It's enough. Deflate. Deflate slowly. So the complete deflation is being done. So now what I'm going to do is I'm going to exchange. The most important, you need to suck the entire balloon, otherwise balloon will get damaged. You have to suck the complete contrast. Then I'll slowly exchange. Now you can see what was the size initially. Now you can see a big opening so that you can easily pull the stone out.
Suppose there is excessive bleeding, what is the rescue?
No, it's not a massive bleed. It's a minor ooze, it will stop. You can see here. If it is a bleed, actually, any significant bleed will be even more, actually, what I'm expecting. But this case, it's a minor bleed. I'll show you now. So once bile comes out, the bleed will stop.
Suppose bleeding is excessive and it is not stopping, what is the?
Most of the time bleed from the sphincterotomy sides. So bleed stops by its own, mostly from the sides. If at all bleed continues, what I'll do, generally we use a sclerotherapy needle to inject at the apex of the sphincter, so that mostly the vessels are coming from the apex, so that it will stop. Second option could be a balloon tamponade. Use a stone extraction balloon. I'll show you, I mean, for a demonstration purpose, how we use a balloon to occlude the bleeding spot and stop the bleed. So this bleed is very minimal. It will stop. You can see the bile is coming. So my assistant is exchanging with the guide wire with the take the wire, lift the wire and put the gas. Wire is there below. Okay, thank you. So I think one of the stone has come out.
Yes, sir.
Where? So for the demonstration purpose, now you can see the balloon. So I'll ask my assistant to inflate the balloon. If there is any bleed, what I'll do actually, like use my big wheel up, just I'll suck the air, lock it. So I'll stop no, it suck and wait for some time. Even if it's a smaller bleed, most of the time it stops. I inflate the balloon, keep it at the papilla where the sphincterotomy site or a sphincteroplasty site, suck the air so that you will get a complete tamponade effect. Keep it for 10 or 15 seconds. Sometimes we keep it for 30 seconds. Most of the time bleed stops. Use some water to flush so that we can see the bleed stopped or not.
Okay, sir.
So what I did actually, I just inflate the balloon. I use a big wheel up so that it just go and occlude the sphincter much better and suck the air so that it completely have a tamponade effect. Now I am putting air little, deflate the balloon. Now put some air, put some water. Now you can see that there is no active bleed.
Yes, sir.
Some more air, water. So there is no active bleed. Can you appreciate now?
Yes, sir.
Okay. So what I'm going to do now, I'll push my balloon inside. Before doing any procedure, what I'll do a trial run, whether my balloon is coming out or not. Sometimes here we have done a good sphincteroplasty, so most of the time it will come out. But no, just want to have a trial run. So what I'll do, so you can put a balloon, small balloon, 12 mm. So I'll ask my assistant to just push it. So just see whether the balloon is coming freely or not. Now balloon is coming freely. What I'll do, I'll go a little inside. You can see the sphincteroplasty, put water, little water. So you can see the bile duct. You can see the bile duct wall.
Yes, sir.
Okay, so now we'll go little and put some contrast for demonstration purpose. We know that how many stones are there. At least out of 3, 1 has come out. I just want to see that how many stones are there and how we are going to take it out. So you can see the stone also. One of the stone just we can view from here itself. You just deflate the balloon. I'll come down. Now we inflate the balloon. Stop. Now put a contrast. Slowly take the air out. Now you can view the fluoroscopy.
Fluoroscopic view.
Fluoroscopy image, please. Fluoroscopy image. Have you got it?
That lower part is not visualized.
You can just bring the camera down. Can you able to see now?
Yes.
Contrast.
Little down.
Yeah.
Could you please tell regarding what contrast is used? How much
We are
is the
using the
concept?
same ContraPack 350 watt radiographers they are using. Can you able to see the duct? Actually, the balloon we have inflated, you can see a stone just below the scope. Beyond that, lot of the contrasts are filling into the lumen and other thing.
Fluoroscopic view can be made it little bigger.
You are unable to get.
Yes.
Anyway, the contrast has gone down. What I'll do, actually, I'll demonstrate. Just deflate the balloon. I'll just go inside. Stone is big. Stone is big. The appearance of stone slightly bigger than what we are expecting. Put some water just to irrigate. There are sometimes stones may not be stones alone. There are a lot of sludge, multiple small stone particles or sludge will be there that will hinder our those stone extractions. So generally, when I see a lot of this material which comes like this, I'll put some water to irrigate the lumen so that it's much easy to deliver the stone. So you can see a lot of small particles are coming out. Enough. So let me try once with the balloon. Go inside, inflate. There is a guide wire. Guide wire, sorry. Fluoroscopy is not seen properly. Wire again. Pull the wire. The wire just come out. Just I want to put this. Yeah, 2 more stones are there inside. Go. Wire. Exchange. Exchange. Balloon.
Sir, anything on the repeated?
Generally, we need to have a good fluoroscopic image and good imaging. It's because without that, we can't do any good ERCP be done, because there's always a risky to see where the wire is going, what is the size of the balloon, size of the stone. It's very, very important to have a good radiographer, good fluoroscopic image. Good visibility is very important. Here I'm unable to, initially I could see the bile duct and stones. Now can't see maybe because of sphincteroplasty per se, but even still with the occlusion cholangiogram, I'm unable to see. So sometimes the stones are quite big and the duct position, it may not come properly. The way the sphincterotome goes, the balloon goes, and I'm not very happy the way it goes. It's hitting. Stone is there inside. You can see the stone inside.
Yes, sir.
And probably sometimes stones will hit and hinge inside the side of the bile duct. Sometimes it may not come. So what I'll do, I'll just put a balloon inflate from here. So I'll push the stone a little up. Great. Wait. Deflate. Small balloon. 1 minute. Inflate. Now I push my stone. You can see the bile duct inside. So ideally, when there is a doubt, what generally we use a basket so that even if it is get caught, we'll crush and remove. Let me try full traction, deflate. Okay, now inflate. Balloon is still. Balloon inflate. I'll go inside, inflate the balloon. Yeah, how do you do a cholangiogram? I'm unable to see the stones. Okay. Okay, system will exchange. Try. Let us try and see. Exchange. I'll see. So you can see the one of the stone is coming out. You can see the stone fragments.
Yes, sir.
I hope one more stone has to come. So the another stone fragments, all fragments. You can see the big stone here.
Yes, sir.
So almost close to 8 mm stones. Traction. Inflate. Okay, so I'm. So now everything is out. You can see the big stone, another stone has come out. So this you can see multiple stones and stone fragments.
Yes,
Two
sir.
big stones and other fragmented stones. What I'll do a cholangiogram. So I'll go reach up to, once again, I'll do a trial run. I'll reach up to the hilum. Yeah, just one. No, one, just. Yeah, the other way around. Yeah, this is a good image. I'll just go there. Still, I have not reached the hilum.
Will you swipe that fluoroscopic image?
Can you switch
Big
over to the
one?
fluoroscopic image? Can you see the image fluoroscopy?
Yes, sir.
So what I'll do for a demonstration purpose, I inflate the balloon, put some contrast so that you can see that the entire bile duct is completely cleared.
Okay, sir.
So you can now you can see the balloon in that close to the hilum. Can you see the balloon is inflated? My assistant is going to inject the contrast. Now you can see the contrast just above the balloon.
Yes.
So what I'll do, I'll just pull the balloon down. Can you see? Till
Yes, sir.
now it's clear.
Yeah.
So I'll pull down some more. So till now it's clear. Are you convinced?
Yes, sir.
So now I'll come out. See one more stone. Can you switch over the endoscopy image? Can you able to see the
Yes,
stone
sir.
at the papilla?
Yes, sir.
Yeah. So now balloon is going to come. So this will give you a complete. So another two more stones. So one more, another. One more stone is coming. So the balloon has come. So you can see the balloon.
Yes, sir.
So now you see the fluoroscopy. Nothing is there, completely cleared. The entire bile duct is
Change the
cleared.
fluoroscopy.
Change the fluoroscopic image. Can you see?
Yes, sir.
So what I'll do once again, I'll with the contrast, I'll just traction. My balloon will go to the top. Again, inflate. My balloon is inflated. Can you see it?
Yes, sir.
Fluoroscopic image, and I'm just pulling the balloon down. You can see the entire balloon is coming without any difficulty. The balloon is out.
Yes.
Are you convinced?
Yes, sir, we could see
Yeah,
that.
so now the bile duct is completely clear, multiple stones were there. It's a nice case for a demonstration, but there are no, so we don't anticipate any bleed here. There is only a little bit of ooze, it is stopped. Now we are going to exchange and we are going to place a stent. Generally, conventionally, this patient has to go for a cholecystectomy. Till then, we place a stent. There are centers when they do lap cholecystectomy in the same sitting, they may not ask for a stenting. There are some centers when the patient's condition is not stable enough or they want to plan it a little later. In case of pancreatitis, they may postpone maybe 2 to 3 weeks later. In that situation, seven. Generally, we use different type of stents, straight stent, pigtail. So my choice would be like just want to keep the bile duct patency. I'll place generally 7 French double pigtail. We were using different type of stents. Most of the straight stents either gets migrated or inside or outside. Very rarely when the duodenum is deformed, sometimes we have seen cases even with a duodenal bend. There is an stent, straight stents will have a duodenal bend. Sometimes even with the duodenal bend, hitting against opposite wall, it can penetrate through the duodenal wall. We have seen cases, so we don't want to have any of these complications. My stent of choice should be a double pigtail stent so that it never migrate inside or outside. So this is from Wilson Cook, 7 French, 7 centimeter double pigtail stent. It'll good enough to keep the bile duct patent. And as a surgeons, would you prefer to have a stent or no stent?
I will prefer a stent, sir.
So surgery is delayed. Probably the Dr. Vishnupada is telling he want to have a stent when the surgery is getting delayed. So want to have a stent. So there are some surgeons maybe because cost involved or when we want to have a redo procedures, sometimes some of the surgeons may ask not to place a stent. But it's always a risky not to have a stent if you do it immediately because always this is a dynamic process. So what I'm just doing is stenting, make sure that my guide wire is in place. Very important that sometimes if your guide wire not in good position, it happens that sometimes guide wire at the beginners, sometimes the guide wire will be placed in the cystic duct. It interferes with the surgery. So now you can see the pigtail part is there out. I'll ask my assistant to take the wire out to deploy the stent. So now you can see that double pigtail stent is being deployed and you can see the multiple stones over here. So with that, the procedure is over. Now there are no bleeds. Actually, are you convinced there are no bleed?
Yes,
The
sir.
clear bile is coming, no bleed. So what I'll do a complete suctioning so that I'll decompress the entire duodenum as well as the stomach. Many times during the procedure, a lot of fluid will be there. So you need to suck that so that it's easy for the anesthetist to extubate much easier. I want suction, it's very weak. Suction is weak. Can you just check the suction? So that's the end of the procedure. I'll just do a suctioning and come out. If you have any question, just post me the questions and we'll discuss.
Yes, sir. It was a very nicely demonstrated procedure, sir. I think delegates will have a few questions. Before that, I have a few questions, sir.
Yeah, okay.
First of all, this repeated cannulation is one of the cause for the pancreatitis. So, any measures you take to prevent the post ERCP pancreatitis, sir?
Yeah. So it's a very important question. So post-ERCP pancreatitis is one of the important common complications. For the beginners, the most important complication is the pancreatitis. That's a very important thing because that prevents your patient getting discharged. Patient will be hospitalized for a long time. You need to that will delay the surgery sometimes. So post-ERCP pancreatitis is one of the very important problem. What generally I do actually, like as I said, the right indication is very important. And for example, a borderline indication, young females, normal duct, and you have a doubtful stones. For example, MRCP showing no stones, there is some sludge is there or possible stones. To attempt that case, definitely will have a likely to have a complication. Not every time likely to have. What general precaution we take? All patients we hydrate. Most important step is hydration of the patient. Most of them, they'll be coming from some other hospital. If your patient is hospitalized, it's fine. Patient who are coming on an outpatient basis, we hydrate the patient. That's the single most important factor to prevent post-ERCP pancreatitis. All patients, we give a rectal suppository with a diclofenac, 50 milligram diclofenac for all cases. That European Society is recommended for all patients. We generally do it whether the patient is benefited or not. Actually, like this will reduce the incidence of post-ERCP pancreatitis. Another important thing is the cannulation technique. Your cannulation technique is correct. You are not middling the papilla for a long period of time. And even when the technique of cannulation should not inject contrast, too much of contrast. For the beginner, they may inject contrast and opacify the pancreatic duct. So in that situation, you may feel that there is a bile duct, but you may be entering into the pancreatic duct, injecting contrast. So that will self cause pancreatitis. So there is a rule actually, like you should not cannulate not more than 10 minutes. If you are attempting to cannulate, then you ask your colleague or a senior colleague. You should not, when you have an edema is there, you can always wait. Or already you have done a sphincteroplasty, you have to place a stent. For example, if you enter into the PD multiple times, we place a PD stent, a small stent, we place it to avoid post-ERCP pancreatitis. Even despite of all these things, patient can have a pancreatitis. But these are the very important things you have to keep it in mind when you're doing an ERCP. Pre-procedural preparation is the most important, I would say. During procedure, a proper cannulation technique and knowing what you're doing. And because you should not be in a harsh to cannulate and traumatize. You should very gentle with the papilla. That's very, very important. You should not be in a hurry. There should not be any heroism actually. You should wait for some time, then cannulate gently. Then you can able to avoid post-ERCP pancreatitis. Then important thing, in case during procedure, you know that this patient likely to develop, then I'll ask my anesthetist to push the fluid. What generally do it in our unit, we'll give a 10 ml per kg bolus. The patient is not hydrated enough. Then we'll give 1.5 to 3 ml per kg per hour infusion, so that we'll push more fluid. And we are going to treat right from 0 hours, so that the incidence of severity of pancreatitis will come down. So the pancreatitis can happen, it will be mild, so that you can avoid any serious severe pancreatitis.
So I am taking Mahadevan for a short break for tea. So please bear with us.
Sir, we are not able to hear you.
We'll start next case in another. Hello. Uday, I'm taking Mahadevan for a short break. Tea. So
yes, sir.
please bear with us for 5 minutes. The
Okay,
next case will be on in another 5-10 minutes.
Yes, sir. Yes, sir. Okay.
Thank you.